Hi, my name is Scott Darnell, RMT, and on behalf of my partner Monica Passanato Forcelli, I'd like to welcome you to the special One Concept Canadian RMT presentation with Erik Dalton. In this lively 1 hour, 100% hands-on demonstration, Erik Dalton takes you through one of his favorite stress-busting mobilization massage routines he's developed from 40 years in clinical practice. This presentation is available now for Canadian RMT CE Library members. The library has over 24 NCB TMB CE approved hours. The Canadian RMT CE Library continues to grow and features the leading educators in massage and manual therapy, including James Wasowski, Tom Myers, Dr. Carrie D'Ambrosio, and more. For just $99, have access to all of these great presentations, CE credits, and certificates of completion until March 31st, 2021. Register now at oneconcept.com. Thank you for joining us today and enjoy this presentation. Be well.
Hi, it's Erik Dalton. I'm back here with my wife, Terry, and we're going to do a routine that I do in a lot of sessions. People come in, they don't have any particular complaints, but they just want to kind of calm that nervous system down a little bit. And I just want to kind of see what's going on, how their body is moving, what things are moving, what things aren't moving. So I do this general routine and go through the entire body. I don't do that much on the arms. That's kind of a separate session for me. This is about a 50 to 55 minute session typically, but we're going to be cutting it in half because I'm only going to do half the body for camera purposes. So I start with the same thing I always start every session with. It doesn't matter what they come in with. I start with a unilateral neck stretch, and that is just so that I can look them in the eye and we're still talking. I've taken a history maybe on these people. They may not have much of a history because they may just be wanting to come in for relaxation, so they're not telling me about, how did they hurt their ankle, da-da-da-da-da. So left hand goes on the forehead, right hand drapes softly, real lazy, relaxed grip over here, and then it's accounted for. So notice how when I move her head to the left, I sweep up, all the way along the posterior lateral musculofascia of the cervical spine. All the way down into the thoracics as far as your fingers will go. Some people can't get very far, but even if you can just get T1, T2, that would be good. Drag on up. Now I'm going to just kind of make my way up the neck. I'm going to do this quicker than I ordinarily would, but notice how I'm stepping from foot to foot. So I can keep my elbows extended so that I'm not overworking, I'm not doing this stuff. I'm really relaxed, letting myself relax. Then I'm going to come in on the suboccipital muscles, starting in the middle at rectus capitis posterior minor, and when I slowly rotate Terry's head to the left, I'm dragging the suboccipitals laterally along the occipital ridge. So you get rectus capitis posterior minor, rectus capitis posterior major. You drop down a little bit and get the inferior oblique muscle, one of the most important and overlooked of the suboccipital muscles. And then I'm going to go all the way out to the mastoid process. Bunch of good stuff at mastoid process, as we know. You got your sternocleidomastoid, obviously, and underneath that lateral border of splenius capitis, which hangs out on the mastoid process. So I'm just going all the way across those suboccipitals with this kind of motion. Typically at this point I would go to the other side of the table and do the other side, but I'm not. Lie on your left side, please, Terry. There you go. Now I'm going to get her back on the table exactly like I want her. Do not work on people side lying if they're not exactly how you want them. Make sure they're up on their shoulder. And Terry, you're good. And then make sure that they're not rolling over, because they'll come in and then they'll get just like way over here like that. There's no way to work on them, and you don't want to work on them in that position. If they come in and they want to roll over, you cannot get them straight on the table. Put their arm behind their back like that. When you put the arm behind the back, it has a tendency for the brain to let that shoulder go back. I'm going to come in with suboccipital work first, since we just already were grooming the suboccipitals in the supine position. Now I'm coming in with both thumbs meeting somewhere along the occipital ridge, right along the rectus capitis major minor area. And notice how my fingers, you can't really see them, but they're draped on both sides of her head. And then the thumbs meet right along that ridge, so they can go right along the ridge. This is the very best way to do suboccipital work, because you can have them do active motions that you can't do when they're supine, like cocking their head back, cocking their head forward, any kind of movements. I'm not going to do that right now with Terry. She doesn't need to do that. I'm palpating gently along the occipital ridge all the way over to mastoid process, finding areas of hypertonicity, which she has one right at rectus capitis posterior major. Everything else is pretty good. And so I'm just going to keep a constant pressure on this at that point. At this point, I am just going to ask her to gently cock her chin toward her chest and relax, and chin toward the chest and relax. And now as she cocks her chin toward her chest, and I have to keep it there, that's stretching it. And now I'm just kind of pushing it up with her. I'm helping her as she cocks her chin toward her chest. I just put a 2 seconds of overpressure, right? Just to help those suboccipitals extend. You can come in also with this technique in a horse stance, elbow against your body, left hand on forehead, and now I've got the suboccipital muscles with my thumb and my fingers. And I start at the suboccipitals, but as I move through the cervical spine, I go back down, and right at C4-5, which should be the apex of the normal lordotic cervical curve. We have to keep the cervical curve in the spine, and we often do not really address that in the neck. And so that's what I'm doing now. There's a counter force going. See, I'm pushing with one hand, elbow against the body, so I can be in this stance up close with her. Left hand's up on the forehead, and now I'm just springing the cervical spine. It also should feel good too. I could do a little corkscrew, having her rotate her head right as I come in. You probably can't see where that thumb is, but that thumb is right in the lamina groove, right in front of trapezius, anterior to trapezius, and you just kind of glide down the groove. Just don't get on carotid artery or anything like that. I'm going to take her arm and put it right here somewhere, way over there like that, because I'm going to come in with fists. Sometimes it's just one fist. Sometimes I'm pushing the shoulder down with my left hand and dragging the tissue toward the spine with the other. You're acting like you're trying to get iliocostalis, which has firm attachments along the rib angles. You're acting like you're trying to drag the iliocostalis down towards spinalis, all the way through longissimus and down into spinalis. So that's kind of the visualization, even though really when you get down in here, it's starting to affect serratus posterior superior, which is really obviously superior and inferior are both real important breathing muscles. So you want to make sure they're activated and working properly on your clients that are having breathing problems. So I'm just kind of sweeping down. If I want to put an activating force through there, if I want her to be an active participant, or I feel like she wants to be an active participant in this particular session, I could have her do something like breathing or pelvic tilts. Just watch what happens even when she starts putting slow pelvic tilts in here. The entire body moves. I can feel the erectors moving in here. Obviously, they have to move. Now I'm going to come on down a little bit, catch a little bit more of the mid-thoracic erectors. And you don't have to use fists. You can use whatever you want. Put this hand behind her neck. She's going to grab her neck there. And I'm going to come in with a flat fist with my fingers pointing toward the floor and my elbow braced gently against my body, and I'm putting that hand against the scapula. Pull it up so I've got a distraction. So it's a counterforce plus a distraction. This is the motion. Right? So you come in, get like that. The first thing I'm going to have her do is she's going to be trying to push toward the wall there, because I'm going to be mainly trying to open up, get some elasticity in the pec major. So here we go. So go, push toward your nose. 2, 3, 4, 5. When she relaxes, I just give it a nice stretch. If the glenohumeral joint is hypermobile, do not do this. Don't do it if the arm comes way back. You know, if it's hypermobile in there, you just do not want to create any more problems than you have to. Do no harm. Okay, now I'm going to go for pec minor a little bit, so it's 135-degree angle, 3rd, 4th, 5th ribs going toward her knees. Same thing here, but this time I'm on the top border of the scapula. Right on the top. Now pull toward the knees. 2, 3, 4, 5, and relax. One more time. 2, 3, 4, 5, and relax. That's good that time. Okay, while she's up there, I'm going to have her grab the top of the therapy table. I'm not going to undrape her for this. Typically, I'd wrap this around and do all that fancy stuff, but for time constraint purposes, I'm just going to do it on the sheet. You can see what my hands are doing better anyway. So she's, I'm just kind of open up this side, get some length in here, right? Just get this thing open a little bit. So I get low. People love this anyway, you know, you're just... feels good to get some of this tissue on the side of the body going. We don't work the sides of the body enough. Pull up on the therapy table. And when she relaxes, I come in. Pull up and relax. Really good technique for the external intercostal muscles. Those are real important respiratory. They work with the diaphragm to lift the rib cage. So it's real important to be thinking about that in this. You're doing a lot of intercostal work here too, as well as latissimus and all those things. And relax. Typically I would come in with a windshield wiper technique where I do the lats like this. But it's too hard to show that, and you guys have seen it on my tapes anyway. I just put my hand on the table. I use this part of the forearm, and I just come up the back like that. It's really good for small ladies who work on big athletes. If you got a big muscular person on the table, it takes the you have a mechanical advantage, your leverage by planting that hand on the table. We'll use windshield wiper again probably in this routine. Now I want to go to a technique that I go to. At this point I would be pulling up a stool. My stool would come in, I would be sitting down where I'm low, because I like to get really, really low on this thing. My palm is going to be right at L4-5, close to the sacrum as possible, without getting up on the iliac crest or anything like that, and fingers pointing toward the ceiling. And I'm just going to do a counterforce here. So I'm just springing this, springing up the rib cage, getting the counterforce going. This feels really good. I could come in with again in a horse stance, get out of the lunge stance and in a horse stance. Push it all out with your breath. Blow it out. There you go. Big inhalation and blow it out. Come back down the lumbar spine, do the same thing, do a little counterforce there. While she's there with her hand above the table, I'm going to come in on right at greater trochanter, drop right off greater trochanter with a soft forearm, and I'm just coming down and working the hip. Working anything that might feel hypertonic in the hip, anything that might help them relax. I know that I, for one, love butt work. There was session 7, and Rolfing has a lot to do. He spent a lot of time working on all the muscles of the rear end there. And I used to just almost fall asleep during that session, so maybe it's because I'm a tight ass. You awake, Terry? She's falling asleep. Yeah, it's really good. Okay. Okay, so I'm going to come in front of greater trochanter now and just catch a little bit of tensor fascial lata. Rocking back and forth. This can be a very tender muscle. Commonly overlooked. You get behind greater trochanter on this side for all the external hip rotators. Get in front for TFL. Typically, I would come down the leg. I'd be on the bicep femoris, right at the border of bicep femoris and IT band. I don't go down IT band. Don't see the benefit, but I do see the benefit in coming down, dragging the hip out between bicep femoris and IT band. That sometimes is a very fibrotic area, particularly on people who are post-hamstring injuries. I'm going to bring this leg back like this. Terry, you can put that arm down now, wherever you like. And this is, she's had hip surgery on this hip, working great now, but you've still got to know that, and you've got to be careful with what you do. So this is going to not look exactly like I would do it in session, but you know what I'm doing. Notice how I have her pinned here with my hip, where I can put my hand, my left hand on the hip, right hand on the knee. Now I can do this. That's knee flexion, so I can control knee flexion. That's the distal part of the rectus femoris muscle, right? The distal part, you can feel it contract. That can be very painful on people, even healthy tissue. And then if you want to do the more proximal AIIS stretch here, all you do is just come in and put hip extension. So that's hip extension, that's knee flexion, but they're both working with rectus femoris. Here we go. So I'm doing them both at the same time, and after you do this for a while, you're able to learn how to just play with it. All I want you to do is push your foot against me. She pushes her foot against my body. 2, 3, 4, 5. When she relaxes, I barely take up the slack. I'm not going to do it, honey. You're all right. Barely take up the slack there, right? And if you need more hip extension, you bring the leg back, etc., etc. Let's get you on your stomach. Now I'm down to the feet, and they're prone. They're feeling pretty groovy by now. I'm going to come in. People love feet work, obviously, we all do. Coming in with my forearm, palm up, and I'm just going to kind of glide down the foot. Kind of catching anything you want. All the aponeurosis under there, and plantar fascia, checking those metatarsal phalangeal joints. Typically do it a little slower than this, but get the idea. Coming in with a webbed dominant hand here on medial lateral malleoli, distal to medial and lateral malleoli, picking the body weight up. If breast tissue is an issue, keep it out here. So I can get this rotational movement through here. I can do figure 8s, which is a mobilization that we always do in the ankles in myoskeletal therapy. We can do dorsi and plantar flexion, not as well, but you know, on your people who've had Achilles injuries, and you're trying to kind of gently stretch it, this is an excellent way to get that, because you got that nice web right up against that Achilles. And as you step here, you can even come into dorsiflexion at the same time and really stretch that without, you know, getting in with your fingers like I used to do, my thumbs and all that. This is just a much better way to stretch it. So you can do dorsiflexion while I'm working on the Fibularis muscles on the outside and the left. Just let it go, Terry. On the lateral side, all the stuff on the medial side, and you're getting gastroc soleus and deep in there, tibialis posterior. Coming on the feet now, and now you're checking cuboid. Make sure that, just seeing how that's moving. The cuboid on the outside, navicular on the inside. So cuboid out here, navicular here, just kind of rocking back and forth. And then bringing the foot into a little plantar flexion, and at the same time, I'm supinating and pronating, which is kind of checking what joint? The subtalar joint, the body steering wheel. One of the most important joints in the entire body, the subtalar joint. So, mobilizing it in any direction you feel comfortable. While she's here, I might as well do just a little bit of hamstring pin and stretch. We all do this. Been around for a long time. Excellent technique. Let your leg drop. Your pin hand, just leaning into the pin hand, dropping all your weight into the pin hand and letting it drop. Letting it drop. So you're pinning. I used to say you're pinning the fascia and allowing the muscle to move within it, but don't think that's exactly what's happening anymore. Science has changed a lot, so we found out a lot more about fascia, the musculofascial connection. And so right now I'm just going in a longitudinal direction up on ischial tuberosity. I use this on all my hamstring injury people, and it's also just a very relaxing technique to have done to you. You all know that. One of the ways that we do not do it typically, and I encourage you to try this if you're not doing it. You come in laterally now. So now I'm pushing all the muscles into external femoral rotation. I'm pushing it that way. I'm pushing the femur, the tissue surrounding the femur, into external femoral rotation. At the same time, get my body weight here and then just dropping my body as a counterforce. So here's a big counterforce going here. Excellent way, excellent hamstring stuff. Just some of the very best ways to work hamstrings. It feels great. You can find out what's tight. You got big palm palpating these muscles. You could feel the difference in tendinosis, membranosus, and biceps femoris, and adductor magnus. So you do that. What I do then is typically, and I will go right to the other side, and I will do the same thing on this side, because this time I'm pushing it into internal femoral rotation while I'm pulling it back. You follow me? Up here when I'm doing it, I'm pushing it away from me still. I'm still pushing this direction, but I'm pushing this tissue out. Whereas when I come over here and I push the tissue out, it's going into trying to encourage internal femoral rotation while I externally rotate the femur. Yeah, so gets a lot of things moving in there. Feels great. All the way down to the knee, work around the knee. Didn't do any of the knee things because they didn't come in with a knee complaint. It's basically the ankles, get the ankles and the hips really nice and mobile. And they're good. Rectus femoris, going to just get a little stretch in the front. Not even thinking about muscles, but rectus femoris is typically what we're doing. Anterior hip capsule, since I've got my palm down here on the proximal femur below ischial tuberosity, then I'm working anterior hip capsule. So there's just checking, see if there's 20 degrees, which is typically most people do not have 20 degrees of hip extension. Iliofemoral ligament, and that hip capsule can get real fibrotic in prolonged desk-occupied professions. Then when I come up with my palm on anywhere on the buttocks, lower buttocks, you don't want to get up here high because you don't want to create a lot of lumbosacral angle. You don't want this thing, sacrum, buckling into L5 because that's not good for the intervertebral disc there. But if you keep your palm here on the butt somewhere like this and you come up, then you're stretching rectus femoris, quads, right? So it's a great technique. Just a stretch, and just do it a couple times. How's that feel, Terry? Intense? Okay, so now as I'm bringing her into external femoral rotation, I'm coming right over on trochanter, on the edge of trochanter. I'm not getting right on the greater trochanteric bursa, no. I'm on the edge of the greater trochanteric bursa, and I'm just kind of, and I'm not in the sciatic notch, pushing on any of those muscles that are involved in what's called the deep gluteal syndrome. I'll be doing a video on deep gluteal syndrome. It's just basically all of the structures that can get nerves that can get impinged in the buttocks area, branches of the sciatic nerve, femoral nerve 2, and pudendal, and then the medial cuneal, right here where I am now, cluneal nerve, right there, and get right on bone. So anyway, just mobilizing it in all directions, seeing what they have a problem with. Come down the lumbar spine. I'm going to undrape you here. Yeah, just keep that arm down like that, or you can put it down all the way. Works too. There you go. Okay, I'm going to come in on the lumbar spine here, and I'm just going to palm, index fingers, braced by fingers and thumbs. So, lunge stance, just coming in. Really palpating, see if there's anything that I need to address either now or later in the session. Or at this point, they may say, you know, that has been bothering me down there. When I get up out of a chair, that right side has been bothering me. So then you have to go into critical thinking and try to determine what kinds of things could be causing that and what you might be able to do to help it. Right now, this is still a relaxation deal. I'm not going to get into it. So I'm going to put this arm right here. I'm going to come in like this and just palm up. I'm going to be moving the tissue in a windshield wiper like this. It's going to be going like this. So I'm catching the lateral erectors, the iliocostalis. Remember the lateral head of the iliocostalis down here. So I'm getting a nice hook here. And now I'm just going to rotate my arm. Notice how I'm pronating my forearm and dragging everything back up toward the spine. Most people need to have this tissue move back toward the spine. Wants to roll off and let the spine go into a hyperkyphotic state, not good. Try to train the brain, the pontomedullary reticular formation, the midbrain, trying to train it in how you want it to be, how you want them to stand when they're not in your clinic. Now you can come in on this side. I don't typically do it from this side, but this is not a big problem. I can just come in and sweep toward the spine. I don't want to get in here and really create too much elasticity in the lower shoulder stabilizers because typically most people, they're a little weak. That's the next thing I would go to try to help that problem. And also, it just feels good to open up this whole chest wall. So I've got her arm behind her back, and I come in with my soft palm under the anterior shoulder there. Left hand goes on the scapula, and then I'm going to rotate it back where it belongs. Ida Rolf used to say, put it where it belongs and make it move. And that was a really good tip, because right now she's externally rotating off, which most people, the scapula will do that. So I'm going to put it back up on here. Now, just gently push your shoulder down toward the table. 2, 3, 4, 5, and relax. And keeping your elbows extended so you're not in here muscling them around. Should feel good. Do that a few times. Now I'm going to grasp her wrist. I'm going to come in with my left hand on the anterior shoulder, and I'm just going to pull this thing, adduct it toward the midline. Then I'm going to ask Terry to gently, with a 20% effort, push her elbow toward me. So she's pushing back toward me, and I resist to a count of 5, 4, 5. When she relaxes, I just take it back toward the midline. Now notice how both hands are working. This one's coming up, This one's coming across the body. That pulls that scapula back down onto the rib cage. The brain goes, ah, that's where you want it. Okay. All right. It's this motion here. And one more time, push toward me. 2, 3, 4, 5, and relax. And I'll bring it back toward the midline. Okay, good. Now I take a duck grip, which is a quack, 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 quack grip. And I'll start with my left hand down first and move the hair up so that I have, look how far down I'm on there. I'm not out here. I'm way down here in the duck grip. And then I'm going to dual duck it. And then I'm just going to come back and forth, squeezing and rotating the tissue. First, I might come with both hands at the same time, just as if I'm pulling all the posterior lateral tissues away from the cervical spine. Start by doing that. And then if you want to rotate, which I typically do, notice how I'm using my entire body to rotate though. I'm not just using my arms. So just rotate, rotate, rotate. Okay, Terry, let's get you on your back. Scoot on down that way just a tiny bit. Let me get rid of this. Okay, we're back to where we started, right? So I'm going to finish this routine by coming in, and I do just we call it the alternate OA. Really, I'm just stepping from foot to foot, pulling up on the sides of the neck as I step to that side. So when I go to the left, that's when I'm pulling up on this lateral fascia. Step to the right, pulling up on the right. Soft finger pads. Distract a little bit too. Get a little decompression in there too while you're doing it. Decompress, decompress, decompress. I come in and just do a little bit of jostling motion here. And side bending. You guys all know we do this routine all the time. This is a part of a typical neck routine. And then I'm going to just decompress, 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 picking her head up, coming in for closing stretches. This is how I finish every session, no matter what they come in with. You've seen this 1,000 times. My body weight up, and I'm going to pull her into neck flexion by pushing down on her shoulders, not cranking on the neck. So I do that. Then I come out of that. Left hand goes on the forehead, bringing her into left side bending, left rotation around my fulcrum, which is my forearm there. See how this is? Nice, comfortable fulcrum. Coming to the other side, doing the same thing. And now 3 big head rolls. 1, 2, and 3. And this is the first time this hand comes off here. Now I'm just holding her head here. So I'm going to side bend left and rotate right. This is non-neutral mechanics in the cervical spine, so you got to be careful with it, but it's a really good way to catch some muscles that are hard to stretch, anterior scalenes and some of those things. Okay, so now I'm just giving it a little stretch by pushing on the shoulder and not by cranking on the neck. So I push that shoulder down to stretch, switch hands, coming over, right side bending, left rotation, and push the shoulder down to stretch. I'm also checking to see what I might need to pick up next session, things that she may have restrictions in, that I need to come in and see if I can help her out. The last thing I'm going to do is have her put her hands behind her head, and we do just a torso twist, just a simple torso twist. I'm just going to do this one side, coming in like this. Just grab the hand, 1, 2, and come in on the hip, and then just drop my body weight and twist. Body weight and twist. They usually know that it's time for the session to be over when I do that. Okay? Thanks, Terry. Thank you. Dr. Carol Lutt, who was an associate researcher with Vladimir Janda over in St. Charles University at the Prague, Czechoslovakia. They did a lot of research on that, but Carol Lutt's famous quote is, "Breathing is our most dysfunctional movement pattern." So first of all, I think we should just talk about what muscles are involved in breathing, how the diaphragm works, and how the pelvic floor, the relationship of the pelvic floor, how the ribs work. We got to kind of explain all that before I bring Terry in and we do some techniques for this. So basically, you got a bunch of muscles that pull up the rib cage during inhalation. The top part, all these muscles here, the sternocleidomastoids, anterior scalenes, and then back you got serratus posterior, superior, serratus anterior, lower fibers of the serratus anterior, latissimus dorsi, pec minor. You know, every muscle that attaches to the rib cage in some way affects breathing, expiratory, out, or inhalation. So exhalation or inhalation, and some of the ones on bottom here, we can see quadratus lumborum kind of. You can either call this quadratus lumborum, you can call it iliocostalis longissimus. But whatever it is, we know that they come up here and they help pull down the rib cage. So the diaphragm tries to unravel, it contracts, and all these muscles pull the rib cage up and out, and all this stuff down here pulls it down. Well, what good does that do? I mean, what is breathing all about? If you don't understand that, none of this makes sense. Okay, so you've got a barometric pressure outside of mercury, which in the air is 760 millimeters. And then in the lungs, we have exactly the same, 760, 760. And it's real important that we have the same because it's homeostasis. So when the diaphragm contracts, the diaphragm, first of all, let's talk about it real quickly, comes around, attaches to all these costal cartilages here on the front, xiphoid process cartilage, costal cartilages, and then it comes around back and attaches to the first 3 lumbar vertebrae down here on this side and the first 2 on this other side. And so it creates a dome so that it pulls down. The diaphragm can come down, the chest comes up, the diaphragm goes down, and what does that do? It drops the 760 millimeter of mercury in the lungs to 759, approximately only 1 degree. And when it does that, that's enough for inhalation. Now, if it, on expiration, muscles of the abdomen, the transverse abdominis, rectus abdominis, obliques, they contract and force air out. So they help do that when it's working properly, but a lot of times it is not working properly. You get what's called paradoxical breathing, where the chest comes up at the same way, and the belly will go down. Chest will come up, belly will go down, and it'll be a reverse pattern. The belly and chest should come up at the same time during normal diaphragmatic breathing. So we want to talk about a few things that we can do to improve this dysfunctional movement pattern that many people have. They don't breathe, they don't use their upper chest breathers. We see a lot of upper chest breathers, or on the people who are kind of the depressed looking slouched people. They're exhalation fixed. They have exhalation fixed ribs, and the barrel chest are upper inhalation fixed ribs. And we talked about that, working on the ribs already. It's important to work on this first rib to help drop the scalenes down. And we developed techniques for pectoralis and all that stuff, and we're going to review some of those. So there are some really good pumping techniques that I found useful for helping to stimulate this diaphragm and trying to teach the brain the movement that we want, the regular diaphragmatic movement. Another problem is in the pelvic floor. If there's gas produced and the pelvic floor is tight, it also has no place to go down there. There should be some play in that pelvic floor, the later ani muscles particularly. And another important muscle group that we have to consider that works with the diaphragm are the external intercostal muscles. You have internal intercostals, external intercostals, and the ones underneath. But we're talking about external intercostals. They insert here. I mean, they originate here and insert on the rib below. And when they fire, they help lift the ribs. So in front, the first 7 ribs, you're going to see this, what we call a pump handle motion, where the ribs come up during inhalation. And then from the side, some of the muscles that affect all this stuff, the lats, serratus anterior, serratus posterior superior, a bunch of these muscles will help the rib cage expand through the sides. The ribs go up like this. That's called bucket handle. Looks like a bucket handle. So that's the swinging motion. The ribs come up like that to expand on the side, and then they expand on the front. So that's what we're going to do. We're going to come in and put some, get on the highest rib we can get our hand on in front or on the side. I'm going to have Terry with her arm over her head. And then I'm going to ask them for big inhalations, and I'm going to pump the external intercostals down. Then I'm going to come on the sides through the whole side of the rib cage and have them a deep inhalation, and I'm going to resist that as they start to go into forced exhalation. When they do forced exhalation, I'm just going to put a couple of seconds of overpressure to spring all of that air out of the lungs, and also teach the ribs what we want them to do, right? And we'll do a little bit of pelvic floor work too, and maybe something else. Who knows once I get Terry in here. So, okay, Terry, come on over here and let's do a few techniques for our most dysfunctional movement pattern, breathing. Keep the legs up like this. We're going to try to test to see if the breathing is diaphragmatic breathing or whether it's paradoxical breathing. So how we do that is we ask the person if we can put our hand on their chest up here and ask if it's okay if put the other hand on the belly. Don't tell them what you're doing, because they'll start to kick in their conscious breathing apparatus instead of the unconscious breathing apparatus. So I'm just feeling to see if normal diaphragmatic movement is happening, where the rib cage and the diaphragm are moving up at the same time. In other words, the upper muscles up here are all pulling the ribs up here, and then we've got all the muscles from below, actually including psoas. Psoas has continuous fibers with the diaphragm down there that attaches the 2 or 3 lumbar vertebrae down there. So they lay on top of one another, so psoas is involved too. So we need to do some psoas work to help with our breathers too, depending on what's going on. Okay, so in Terry's case, let's say she's got normal diaphragmatic breathing, but when she comes back down in her exhalation phase, she's all pumped up here. When she comes down at exhalation, if it doesn't come down very far, if it just kind of stays up there, then you know they've got an inhalation fixation. The muscles up here, sternocleidomastoid, all the scalenes, all those upper rib elevators are all a little bit hypertonic and not letting go. So we want to help encourage those to go down. If they will not contract back up this direction, if they can't come back up, they're breathing, but it's just not, you just don't feel it on exhalation. The muscles kind of contracting. That's when the stomach muscle is supposed to contract. The diaphragm is relaxing, right? So then you know maybe you have a problem down below. Typically what you see is a lot of, in this stressed out society, a bunch of upper chest breathers that don't really use their diaphragm. So we're going to help them help stimulate some tone in the diaphragm. A lot of ways to do this. Sometimes I like to start, since she's already supine, I'll just do it supine. I'm going to put this arm up over her head here just to get a little bit of stretch in here, you know. That's what we're trying to do, is to get this to stretch open here so that it puts pressure on the lungs to inhale, causes the lungs to inhale as you take a big breath, and when you exhale and let it all out, it compresses the lungs and you exhale. Come in here, I like to use horse stance with my elbow against my body, and I come in on the side of Terry's rib cage right here. I ask her to take sometimes I'll hold the arm like this where I'm getting a stretch through there, and ask her to take a big breath and exhale out your mouth, let it go. And when she does, I pump it for about 2 or 3 seconds on exhalation, because that's what all that's supposed to be doing. I follow inhalation, big inhalation, and exhalation. Throw it all out. Blow it all out. Inhalation. You know, depending on if you feel that it's restricted in there, but you're kind of retraining the brain that you want to those muscles and rib cage to be able to collapse back in. You don't want rib fixations, funky ribs that are not able to spring. And that's what we see a lot, particularly in males. You see a lot of ribs that won't spring, and so the muscles will finally just give out. They don't have any reason to try to force the ribs to move if the ribs don't move. You can do this also with both arms up and at the head of the table. Depends on your size, length of your arms. You can come in like this and do both sides. And again, it would be like this. Big breath, and I follow her, no big deal. I don't put a lot of pressure. On forced exhalation out of the mouth, I start to just give it a pumping motion. Inhalation again, Terry. And blow it all out. And then, okay. So I said the diaphragm was the main muscle of inspiration, obviously, but the other important muscle of inspiration is the external intercostal muscles. So the external intercostal muscles, we talked about them running from the superior vertebra to the one below, pulling it up so they contract all this up, particularly through T7, these ribs through here. I don't like to do it when they're supine. I can do it, I will do it, but what I want to do is I want to get on the bottom rib, whatever the highest rib I can get on the top edge of it, and have them gently inhale, and I hold it down. And that stretches the external intercostal because they're trying to pull that rib up. So if you just kind of gently hold them down, go all the way down. Ida Rolf and Rolfing, we used to have to come in and go through each rib. Session 1, go through the intercostals with extended fingers. It's a pretty painful session. I had a lot of people that didn't come back for session 2 and when I started that. So there's a way to stretch it, and this is actually one of my favorite ways. Let's just get you lying on your left side. Is that okay? Is your head okay like that? Or do you need a pillow?
That's fine. That's fine.
Okay, so let's get up here like this. So what I'm going to do is I'm going to try to get on the highest rib possible. That I'm on the top edge of this now. And the external intercostals run this direction, right? The intercostals run this direction. External intercostals are the ones we want, so they're running that direction. So at first I usually just try to take the rib down, don't worry about the fiber direction. So here we go, and I'm just going to ask her to take a big breath, but not a huge breath, a big breath. And I'm just holding it down. I pump it a little bit, but I kind of hold that down to stretch the intercostals. In other words, this one is stretching because I'm holding the bottom part of it down. It's trying to pull up on that rib, but it can't, so it gives it a stretch. You can also go ahead and put pressure on exhalation too. As she exhales, I can go ahead and push that thing down, which is following the diaphragm. And now when she tries to inhale, I resist. Just go down rib by rib by rib to cartilages here at 9 and 10, between 9 and 10. So you'll be holding down 10 and having them inhale to stretch that between 9 and 10. Of course, all breathing work for me includes springing from the sides, just general springing. So I'm going to come in, watching your hand position. I have my clients appropriately draped. I get my body weight low, center of gravity low, where I'm feeling firm, keep my forearms firm, and I'm just kind of feeling around here for the best grip on the thoracic cage, because I want to get some in the back, some ribs in the back and some in the front. So I'm going to keep this mild pressure on downward on the ribs, and I'm going to ask her to do the same thing we did in the front. Big inhalation and blow it out, big on exhalation through the mouth. And when she does, I spring them down, just help them. Again, going down a little lower now, down to about 8 and 9, and in the back I'm almost to the floating ribs. I'm at T10, T12, T10, 11, the back. Okay, come on up and back down. And just spring them. I mean, you can sit here and spring, even if the people do not want to be actively participating in this. This is at least a good rib mobilization. If you feel some sort of fixation, you need to address that. For instance, if I felt something up here at the top right under her scapula that wasn't moving, there are a whole bunch of different kinds of things you can put in there, including, okay, elbow here, I'm on this ribs that's just a little bit not moving, and then I'm just going to jostle it with a counterforce. This is coming from my hip, my elbow and my hip. I'm just rotating my hips now, and I'm giving a little bit of traction here, just a little bit of counterforce here. If it doesn't seem like it's doing anything, hold there. You may want to come below and see if that's the problem. And ask her to take a big breath in. And all this rib cage stuff is good. Pec minor, got to do pec minor, got to do the anterior scalenes, got to do sternocleidomastoid. Don't worry about serratus posterior superior in the back, because typically those muscles aren't real strong anyway. They've got to hold the erectors in, and they get weak and allow the erectors to spread. And so they need to be tonified more than they need to be released. Latissimus dorsi does need to be released, and we talked about a bunch of techniques to release that. One of them is where you're coming up the side of the body. I'm bracing here, forearm like this, and I'm just hooking the fascia with my flexor part of my forearm and slowly coming up, catching the very lateral edge of latissimus dorsi. Then you can come back and do the windshield wiper thing that we've talked about before, where you're catching the lower borders all the way down into the lumbars. So you get the erectors and get latissimus dorsi. The pelvic floor release that I still like the best, and you guys have seen this before, I'll need to take this leg down straight. There we go, just like that. Typically what I do, I have them really spread out on the table, and I have a pillow under here so that the leg is actually sitting like that. But this is okay. It's not that big a deal. It just twists the fascia, just twist everything this way, right? But that's not a bad deal. I'll come in here, and I'll take the leg, and I'll kind of pull it into internal femoral rotation, at least the tissue. I'm not necessarily pulling the bone, but the tissue into internal femoral rotation. Then I'm going to ask the person if I can use my forearm here, this thing right here, to come slowly up your leg on the side like that, and then is it okay if I bump into kind of your buttocks up here with my forearm, because I'm trying to affect pelvic floor muscles that may be causing you some difficulty, and I just like to get in there and stimulate that. Is it all right with you? And they go, yes, that's fine. So I put the leg into a little bit of more internal rotation right here, so I have something to hook against. Forearm, palm up, and as you start slowly coming up, and I'm doing it faster than I ordinarily would, I'm just coming all the way up the leg, kind of catching all those adductors there, because we're basically talking about the adductors, how they are fascially connected with levator ani and a lot of the pelvic floor muscles that helps stimulate tone in there. So you come across, all the way across that pelvic brim, that right below the ischial tuberosity. So come up several times and then just stimulate tone in there. Sometimes I have them pelvic tilt while they're doing it too, just to put activation through there. So just do slow pelvic tilts. And then I stimulate tone too. So we're both kind of moving on it. And of course, there's always a test to see if one side of the pelvic floor is weaker than the other. Things like episiotomies and all sorts of surgeries that we get, men and women both get, can weaken the pelvic floor. So to test, you just find ischial tuberosity, make sure you know where your ischial tuberosity is. And you come in as if you're going to do sacrotuberous ligament work. You come kind of right under there. There's a space that's just kind of a soft spot right off ischial tuberosity. It's superior and off to the left, lateral. And that's where you just kind of take thumb pressure and put it in here, this. And then I ask her to just take deep inhalation and exhalation efforts. And when on deep inhalation, a big inhalation, big breath in. Okay, so she's pushing back now. Of course, she just got back from Pilates, so probably stimulated. But the pelvic floor should push back against you when they take a big breath, right? Just try it before you start doing it on your clients. Try it on a family member or something. Just get on ischial tuberosity, go a little bit lateral. I mean, not far, a thumb's width away, kind of like you're going toward coccyx. And there'll be a spot in there. And then when you hold constant pressure and they take a deep breath, it should push back against you. Test both sides, the levator 80 and all that stuff. Coccygeus and all those on one side can be weak and inhibited from whatever, and the other side could be normal. So that's the side you want to stimulate tone. I actually do stimulate tone through there just by keep having them either do pelvic tilts or inhalation, exhalation efforts, or both, while I just kind of bring awareness to the area. You need to practice this on somebody first, so that you really you're confident exactly where you are. Because people know instantly if you know what you're doing, and then they trust you, and then you get a lot better therapeutic outcome. You always need to do something with quadratus lumborum down here. Help it. I'm going to come off the table like that. We've done this before, but this is a little different now. We're talking about breathing. And so when she takes an inhalation, big inhalation, that's when iliocostalis, the most lateral erector, longissimus, the medial erector, and quadratus lumborum, the fifth layer abdominal muscle. People think it's a back muscle. It's a fifth layer abdominal muscle. So what that fires the same time the diaphragm does, right? So it's pulling all this stuff down along with psoas, right? They're all pulling this down, and then you got your fixators up here pulling from that direction. The external intercostals, diaphragm, everything pulling from that direction, and that gets that causes the inhalation. Stretches that out, causes the lungs to expand out. Inhalation. Okay, so we've done this a lot before, but I'm going to do this a little differently. I'm going to come along the brim of her pelvis here, get way down. I actually like to, if possible, get my arms real close in here like this. And then I'm going to have her put this arm over your head like that. And then take a big breath. And when she takes a big breath, I'm resisting. When she exhales, I'm pulling it down. I'm pulling it down. I'm training the quadratus lumborum to pull down, pull all this stuff down. A big breath. Good technique for teaching the brain how to do normal diaphragmatic breathing. Sidelining work for psoas is really my favorite way to do it, because when they're prone and you're trying to lift that heavy straight leg, I mean, we do have a little trick that we use in mat to do that, but this is the best way to do it, because we can even allow them to slide their leg off, on the table to keep you from having to pick up that heavy leg. So I'm going to come in and brace at the hip, lower part of the hip, because I don't want to cause any excessive lumbosacral angle and cram L5 and S1 together. Don't want to do that. So I'm going to come in like this first, elbow against my body, palm on her buttocks, and come in and do this. And then ask her to gently, and I mean gently, push her knee toward her nose. 2, 3, 4, 5. And when she relaxes, oh, I know, this should be okay. She's had hip replacement here. So stretch it like that, right? Here's another way to stretch it too. You can let go of that and just put the legs down. I like to do this too. You sit on the table. Bend your knee. So you sit on the table, so you're bracing them now with your side against their buttocks. Wow, that's very firm when you can do that. When you can brace them here, and you can extend the knee to make sure you're not getting any rectus femoris in there, right? Or you can do a little bit of knee flexion and it doesn't hurt, as long as you don't feel these the rectus femoris really firing. So see how I got a counter force going here? And I would have her be active, have her push against me and all that contract, relax stuff. And get the psoas moving. So there's a whole bunch of stuff that we can do with ribs, but as long as you kind of understand the basic functioning of ribs and why gases always go to the lower pressure gradient to cause breathing, and how the diaphragm and all of those muscles work to give us proper breathing and get rid of those dysfunctional movement patterns that Carol Lewitt was talking about, all right? Okay, thank you.